Good morning, good afternoon, and good evening to everyone who is joining us live, and welcome to those listening in afterwards. Welcome to our event, Health and Self-Care Literacy for the Management of Minor Ailments in the Pharmacy. Today's focus is on body pain management. I'm very pleased to be moderating the event today alongside my colleague Noor. My name is Lina Bader. I'm the FIP Lead for Equity, Sustainability, Policy and Development. Supporting me and facilitating today is Noor Tahla, FIP Projects Coordinator for Equity, Sustainability, Policy and Development. Thank you, Noor. Some quick announcements and housekeeping before we begin. This webinar is being recorded and live streamed via YouTube. Our YouTube channel is FIP. You can find that by searching YouTube. The recording will also be available on our events website, events.fip.org. You may feel free to ask questions using the question box at the panel below in the Zoom window. You are welcome to, of course, always provide feedback on this event and all our events by emailing webinars@fip.org. And if not already, and you'd like to become a member of FIP or understand member benefits, please visit our website to find out more. We'd like to also quickly acknowledge that this webinar is sponsored through unconditional funding by Reckitt Benckiser. Shaping the future of self-care through pharmacy is this year's new FIP program of digital events. Empowering patient self-care improves health outcomes and reduces the burden of diseases. And improving health and self-care literacy is therefore key to empowering pharmacy-based self-care. This is an important principle we believe at FIP, and it's especially important when it comes to the management of minor ailments in the pharmacy. This digital program consists of a series of 5 events. This is the second of them today on common health issues. And it aims to examine how pharmacists can be enabled to improve health and self-care literacy across those minor ailments. The approaches for 5 different areas of minor ailments will be discussed, including embedding health and self-care literacy into education and training, developing self-diagnosis and self-medication protocols, widening access to patient information, and improving referral strategies. These are among the many factors that will be discussed throughout our series. This event today, focusing on body pain management, is the second event in the series, as I mentioned, and today we'll focus on the management of body pain. In this regard, pharmacists hold a vital position in enhancing health and self-care literacy for pain management. Better health literacy skills in individuals can aid in comprehending their pain condition, expressing their symptoms to healthcare providers, and adhering to treatment plans, which ultimately result in improved self-care, pain management, and of course, quality of life. So today's objectives, very briefly, understand the key clinical issues and literacy needs when it comes to the management of body pain. Identify strategies for pharmacists to enable health and self-care literacy in the management of body pain. Discuss enablers as well across education, training, care protocols, services, etc., to support this agenda. Very pleased to welcome our panelists today. We have Muriel Schneider, Jonathan Pem, and Iqbal Fahs from all around the world joining us today. And I'll actually invite my colleague Noor to introduce our first speaker. Noor, the floor is yours. Thank you.
Thank you. Thank you very much, Lina, and thank you everybody for joining us today. Thank you to our exceptional speakers for joining us to share their knowledge and expertise with us. Let me introduce you to our first speaker, Muriel Schneider. Muriel has led projects and programs for over 10 years in diverse health areas across pharmaceutical and food industries, academic and NGO settings. Muriel holds a PhD in infectious disease and immunology for her work, which contributed to the discovery of the meningococcal B vaccine. This led to postgraduate research in the related fields of gastrointestinal immunology and NCDs at the Harvard Medical School, Novartis, and Nestlé. Following periods, delivering projects for Merck, the International Osteoporosis Foundation, and the Wellcome Trust, Muriel now leads strategic initiatives at the Global Self-Care Federation, including one focusing on improving and enhancing health literacy at a global level in self-care. Muriel, the floor is yours.
Thank you, Noor, and thank you, Lina. Hi, everyone. First, thank you very much to FIP for inviting the Global Self-Care Federation on this webinar. It's my pleasure to share with you what our organization is doing on health literacy in the context of self-care. So let me start with what we mean by self-care. Self-care is defined by WHO as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and cope with illness and disability with or without the support of a healthcare provider. So this is a very broad definition. And just to give you an example, self-care products includes over-the-counter medicine, but as well vitamin, mineral supplement, or even like medical devices. And we call self-care intervention, self-care that are including self-care, self-management for chronic disease, self-testing, like we have been using extensively COVID tests, and self-monitoring that is more in the context of a digital health like diabetes devices. Next slide, please. So looking at the self-care continuum, you can see that self-care is present at different health status of individuals. So from a healthy person making daily healthy choices such as brushing teeth, to treating minor ailments like body pain with over-the-counter medicines, or even as we move towards to the right-hand side of the scale, supporting chronic diseases, and even when we look at the fully supported by the hospital major trauma, recovery is often involving self-care intervention. Next slide, please. So this is just another way to show you that self-care is playing an important role in the healthcare system, and that shouldn't be seen as a nice to have element. You can as well see how pharmacists are playing a crucial role in this field. They are the primary healthcare professional, educating and empowering individuals practicing self-care. Next, please. So just a few words and numbers to show you why the value of self-care will strengthen the overall health system response. With the rise of chronic diseases, the recent pandemics and potentially future ones, the predicted shortage of health workers, embedding self-care practices into a healthcare continuum has the potential to improve health and quality of life, as well as making the health system sustainable. So last year, GSCF demonstrated the economic and social value of self-care. And I will put the link in the chat session for all the documents I will mention. But in a nutshell, looking at the value of self-care, it was shown that at a global level, current self-care activities are generating approximately $190 billion of savings, of cost saving. And this is, just to give you a rough idea, this is close to a GDP of Morocco or Hungary, for example. And on top of this cost containment aspect, self-care relieves the burden on healthcare providers by saving them 1.8 billion of physician hours. That will allow them to attend to more severe health conditions. So I'm not going to go through all the numbers. We have a big report on that, but this is just to give you a sense on how self-care can sustain a health system. Next, please. In the same report, recommendation highlighted how essential health literacy was to enable self-care. Self-care belongs to individuals, families, communities, and we've seen healthcare professionals, but policymakers too, at different levels with different responsibilities. It's for us a primary responsibility of policymakers to design the right environment for each stakeholder to fulfill their responsibilities. So along with the economic and social value of self-care, another key report assessing the readiness of countries in self-care was published last year by GSCF. Next, please. So looking at the specific health literacy indicators, we could see quite different progress in terms of putting health literacy on the policy agenda at a national country. Some already had developed guidelines and framework, while others had no nationally scaled programs. So next, please. And in this report as well, we also highlighted how pharmacists can play an important role in facilitating effective self-care. and pharmacists are often ranked as the most accessible and the most trusted healthcare professional. This is why building from previous collaboratives with FIP, such as a joint statement on the role of pharmacists in self-care. Next, please. So now I would like to show you what we have been recently working on, specifically on the policy side for health literacy in self-care. Next, please. So last year, we conducted a research study with Christine Sorensen, who's a health literacy expert recognized worldwide, and we published the results and key recommendations in a white paper. And the research conducted highlighted two types of individuals having different behavior. We had a health literate person who would be more focused on maintaining health, preventing action. A self-care literate consumer tend to actively engage in health promoting activities, using the internet more frequently to gain information, like for health via health portals. And in contrary, a limited health literate person tend to have less focus on prevention and health promotion. It's often the group that requires interventions more urgently due to their worse health status. So based on the many difficulties in decision-making, in the high-frequency usage of OTC medicine, there is a big potential to engage with less self-care literate consumers. And this is where pharmacists can specifically help to support limited self-care consumers in order to provide information and overcome communication barriers. Next slide, please. So in summary, it is clear that one size does not fit all, and there are different challenges according to whether you have a health literate versus a limited literate individuals. And intuitively, being health literate will contribute to a better health and well-being life. Next, please. So to promote and enhance health literacy, a set of recommendations were defined around 4 pillars: policy impact, information and communication, capacity building, and analytical insights. Just to name some of them, we could do more work on identifying and mobilizing literacy champion, improving clear information on product, enhancing self-care education to HCPs like pharmacists, or gathering more evidence-based research. Next, please. So GSCF has started to work on some of the recommendations, and actually 2 weeks ago, FIP, along with 9 other organizations, participated in our first GSCF roundtable on self-care literacy, where each participant were engaged and share their current projects and vision on how to collaborate to further promote health literacy. And Dr. Kresch, director of the Health Promotion Unit at WHO, supported this meeting, putting into the whole context of the WHO well-being agenda. So that's something that we want to further continue to allow and to build a global roadmap where each of the stakeholders can play a role. Next, please. We develop as well different policy tools for members to support them in implementing and in pushing for health literacy policy agenda at a national level. So these are still under development. They will be hopefully in the next few weeks available. But so a toolkit is providing insight on an implementation plan, best practices, talking point to different stakeholders, and we have as well a policy brief for policymakers discussion. Next, please. Finally, I would like to touch on another important recommendation, which is increasing digital literacy. With the COVID-19 pandemic, that has further accelerated the shift towards the digital world, creating an opportunity for the wide use of electronic product information, or EPI, particularly in low and middle income countries where risk communication was done using digital tools. So EPI can be an essential tool in empowering consumers to address their healthcare needs. And therefore, GSCF published a position statement promoting the use of EPI as a main end state. Next, please. So digital health literacy offers many advantages, and just to name one, it allows to reach out to individuals with specific needs. So for example, elderly or visually impaired people could use other features on an app to access the product information, like visual ads, large size fonts, audible format can be included. Next, please. So to summarize, health and self-care literacy is everyone's business. There is a great potential for healthcare providers and other stakeholders to involve consumers more. It's crucial to empower consumers in decision-making processes, in enhancing their self-esteem to engage not only healthcare and prevention, but as well in health promotion and well-being. So boosting the capabilities and the capacity of the workforce involved in providing such self-care support is necessary to enable them to respond adequately to people with limited or high self-care literacy. So there is an opportunity to involve pharmacists in the communication process with consumers, as they are the healthcare provider group working the most closely with them. And on that, and thank you very much for listening.
Thank you very much, Muriel, for that very informative presentation. And thank you for sharing your knowledge on self-care and health literacy and explaining how they both help in sustaining a health system. I'm sure we will be receiving so many questions that we can address towards the end of this webinar. But for now, please allow me to introduce our second speaker for the day, Dr. Jonathan Penn, who is a pharmacist and senior lecturer at the University of Sydney. Dr. Penn's research focuses on improving the safe use of medicines such as opioids for pain management. He has published over 100 peer-reviewed publications and is secretary for the FIP Hospital Pharmacy section. He's chair of the Research Leadership Committee of the Society of Hospital Pharmacists of Australia, SHPA, and is vice chair of the SHPA New South Wales branch. Jonathan, the floor is yours.
Thank you, Noah, and that was a great introduction by Muriel around the importance of health literacy. Right now, I'm going to take you a walk through about the importance of pain and how I can link pain and self-literacy and things that we can do as pharmacists to improve our patients' well-being. So to get started, these will be my learning objectives. I'll talk about the impact of pain and then how health literacy impacts that. And lastly, I'll talk on the gender pain gap. So the thing to keep in mind about pain is it's not just pain. Pain is the leading cause of disability, disease burden globally. Out of all conditions in the world, pain is the leading cause of disability. So there's a few reasons for this. We know about 20% of adults experience pain, 1 in 5, but that's not the main reason for disability. I've got here a pain spider. So the typical Australian has to bring the word spider into it somehow. But pain is not just pain. People with pain, it impacts their sleep, gives them fatigue, impacts their work, impacts their concentration, impacts their family life, impacts their social life, impacts their mobility, and impacts their mood. So pain is bigger than pain. Patients in pain often will have a large element of disability and disease burden on them. And that causes a huge impact, not just to the individual, but to society as well. Here's some stats from Australia to give you an idea of why it impacts society so much. So we know that around 68% of people with pain are at working age. And if you're working with pain, you can't work well, right? People are more absent from work. People may be present, but not working at the full scope that they can because of the pain. 40% of Australians retire early due to pain. And, you know, it's costing us around $50 billion. This is just our little Australia. It's little Australia. The other part to push forward is that it does have a mental health component. We know that 2/3 of people with arthritis say that the condition affects them emotionally. You know, people with pain have 4 times the rates of depression. And it's not just that pain causes depression. It's also, you know, mental health depression can lead to worse pain. So there's this cyclical loop. But the whole idea is that pain is bigger than just pain. It can affect their whole life, their mood, their work, their social life. It's bigger than just the individual. It also affects society when 2/3 of these patients aren't able to work at their full capacity and people are retiring early because of their pain that's not managed. In the US, they found that about 3 billion A year is probably due to healthcare costs and 335 billion due to societal impacts, again, due to that absenteeism that I talked about, or presentism, where they're at work but not able to work at their full capacity. And if I compare that to like heart disease or diabetes, we actually see that pain costs more than heart disease and diabetes. Yet think how much more resources and education are put into heart disease. Now I'm going to try to link that health literacy and pain connection. We talked about health literacy being that skill set of how people access, understand, and use health information to benefit their health. I'm going to start with a pharmacy example about health literacy just to get you in the mode, just to get you thinking about health literacy. A pharmacy example, a very common one, is like our pharmacy dispensing labels. So like a lot of parts of the world, Australia, we print out dispensing labels and we stick them on the medications to give to the patients, and that gives them information on how to use their medicines. Now, I conducted some research here in Australia with user testing, and these are 3 different types of labels. The first one on the left is our very traditional label using all caps to signify 2. Maybe to use it 2 times a day. So I'm going to focus on the frequency of this. So the first one on the left, 2 times a day using all caps letters. The middle one says now 2 times a day, but using figures instead of letters. And the last label on the right, now instead of saying 2 times a day, it says use it in the morning and use it at night. Use in the morning and using it at night. And let's see how our patients did when we asked them, how often should you use this medicine? If you were given this medicine, when would you use it? We found with the first label, the most common label that we use, that they've had about, I think around 75% got it correct. That means 25% of people got it incorrect. 2 TWO already lost some people. We changed those to figures because people understand figures better than words, particularly if they don't speak English, they can still recognize the figures. And now their understanding increased to 90%. Fantastic, but we're still missing some people. We're still missing 10% of people if we're using figures instead of words. But last one, we actually said in the morning and in the night. 100% everyone understood it. So this is just a very easy example of how everyday things that we do in pharmacy can actually impact our patients and how they manage their medicines. So let's look at it in the scope of pain, in the scope of pain management. So there was a literature review done in 2022, just last year, included 20 articles, and they found people with lower health literacy had poorer pain self-management. So they had lower pain knowledge, lower medication knowledge. They also found that people with lower health literacy had poorer outcomes. They had worse pain intensity, more disability, worse quality of life. So we know not only does health literacy impact how we manage our medicines, how we manage our health, it has a direct impact on how we manage pain. And so health literacy is something we need to be aware of. The language we use matters. How we present information matters. There's also other things that we can do to improve. And I wanted to bring this up because FIP has a report on this recently. It's looking about gender bias. So it's not only are the words and the language you use matter, they also seem to change depending if we're talking to a male or female patient. And those are things that you need to be aware of. This might be deliberate, but often it's not. Often it's not. So a systematic review again in 2018 later found 12 papers looking at gender bias in pain treatment. And what that means is that they had patients, it was just on paper, simulated cases, but the presentation and symptoms were exactly the same. The only difference was it was a male presenting or female presenting. Okay, all the symptoms, everything they described, their history, everything was 100% the same. The only difference is was it male or female. And they found that women generally received less pain release, less opioids, and more antidepressants, anti-health referrals, even though they had the exact same symptoms. And this moves into the bias that some people have that, you know, men are considered more stoic while women are considered more hysterical, emotional, complaining. But we are giving different recommendations depending on who we talk to. We are choosing different language depending on who we talk to, and it's important we recognize that in ourselves, because this just shows that we have room for improvement. This is the FIP report I talked about if you want to read more, but just know that your bias can impact the care you give. There's two types of bias, just to be aware. There's explicit bias, which is stuff that's very openly clear when we say, oh, you're female patients, so you shouldn't need any pain medicines, which isn't always true. Or there's implicit, where we just imply it. It's a bit of unconscious bias. And that one's much more difficult to address. Lastly, just as I'm going to finish up, is I know you're here to learn a lot about pain management, and luckily Iqbal is going to tell us a lot more after me. But one thing I wanted to highlight is there's a free online pain management course that's been developed in Australia, used in over 60 countries. It's free, it's online, it's evidence-based. If you want to read about it, there's a journal article. But if you go to this link here, anyone in the world can access it to improve their knowledge about pain medicines. Thank you very much.
Thank you very much, Jonathan, for that very informative presentation. And thank you for highlighting the impact of pain on not only individuals, but on whole societies. I'm sure we will have a lot to talk about in the panel discussion as well. I'd like to move on to our third speaker for the day, Iqbal Fahs, who is a motivated pharmacist with real passion for healthcare and more than 10 years of expertise in academic, community, hospital, and industrial pharmacy. She's a clinical assistant professor and experiential education coordinator at the Lebanese International University, with research interests in pharmacy, practice, and education, adolescents' health, mental health, infectious diseases, and cardiology. Iqbal, the floor is yours.
Thank you so much. Thank you for the opportunity today to join you and to talk about pain management and the role of community pharmacists in improving their patient outcomes. So I'll go briefly over pain definition, assessment and management. Then I'm going to go over the role of pharmacists in helping to improve the patient outcomes. So starting with the pain definition, actually pain is a multi-dimensional experience that affects mainly the quality of life of our patients. There are several definitions. The most commonly used one is for the International Association for the Study of Pain, the IASP. According to IASP, pain is an unpleasant sensory and emotional experience that is going to be associated with the actual or potential tissue damage, or described in such terms. According to the IASP, the adults are going to experience around pain yearly on a global basis. Around 20% of the adults are going to experience pain, and around 10% are going to be diagnosed with chronic pain. So based on that, pain is going to be considered one of the most important issues in healthcare today, and we will try to help our patients to improve their outcomes as much as possible. Moving into the pain assessment, pain is subjective feeling, meaning that there's no accurate or ideal tool that can be used in order to assess pain and to measure the level of pain. We have various scales that can be used, including the visual analog scale, the verbal rating scale, the numerical rating scale, among others. For the classification of pain can be classified based on different factors. These are the most common factors that we use to classify pain, including the duration into acute or chronic. Usually, any pain lasting for less than 3 to 6 months is considered acute. If it's lasting for more than 3 to 6 months, it's considered chronic. For the location, it depends on the site of injury, whether back, stomach, joint, musculoskeletal pain. Based on the intensity, it can be classified into mild, moderate, or severe. And based on the etiology, it can be classified into the nociceptive or neuropathic pain. For the nociceptive pain, it could be somatic or visceral, depending whether it's a localized or non-localized pain. If it's localized, it's mainly somatic. If it's non-localized dull pain, then it's due to an injury that's usually associated with or mediated by the stretch receptors. So it's referred to as visceral pain. For the neuropathic pain, actually, it's due to a dysfunction or injury for the nervous system that could be central or peripheral. This classification is important because despite being or having pain that can be appearing in a single defined entity. However, in most of the cases, especially in patients with a chronic pain, we will have the demonstration of pain as a complex pain with several types combined together. For the management, how to manage pain, we have mainly the non-pharmacological methods along with the analgesics. So starting with non-pharmacological methods, they aim to alter the focus and the concentration of our patients so that this will help in reducing their pain. We can go for cognitive behavioral therapy, hypnosis, for comfort therapy, including positioning, exercising, companionship, body or heat or cold, meditation, in addition to others. We can go for physical and occupational therapy, counseling, which could be individual, family, or group counseling, also neurotranslation, neurostimulation, including acupuncture and aquapressure. As for the pharmacological management using analgesics, the main classification is into opioids and non-opioids. The opioids are the most effective. However, they are reserved till the last because they are associated with risk of toxicity, addiction, and tolerance. So we try to reserve them till the end, and we use the lowest effective dose for the shortest duration possible. And they are used in the management of moderate to severe pain. For non-opioids, we have several classes, including acetaminophen, used in the management of mild to moderate pain, but not neuropathic pain. NSAIDs for mild to moderate pain as well, and for musculoskeletal or inflammatory pain, but not for neuropathic pain. We have the antidepressant like PCA, amtriptyline, and like SNRI, duloxetine. We have anti-epileptics like pregabalin or gabapentin, which can be used for the management of neuropathic pain, especially peripheral neuropathy, and local anesthetics like lidocaine, which can be used in the management of post-herpetic neuralgia and peripheral neuropathy as well. So the importance of these drugs is that these drugs can be used in the management of pain. They are going to be dispensed either as OTC medications, mainly acetaminophen and some NSAIDs, based on the dose. And we have the rest as prescription medications. So we can play a huge role in tailoring the therapy and in helping our patients to avoid side effects and to monitor for any symptoms, signs and symptoms of toxicity. This is the WHO ladder, which was introduced in 1986 as a method to help management of pain in a stepwise approach. It was approved for cancer patients, but later on it was adopted by for the management of the non-malignant or non-cancer pain. So initially we start with for the mild pain with non-opioid and adjuvant therapy if wanted. Then we can go upward to use weak opioids in addition to the non-opioid and adjuvant. Weak opioids like codeine, like hydrocodone or tramadol. And if the patient is still in severe pain and the pain intensity is intensifying or increasing, then we have to substitute the weak opioid with a strong opioid like methadone, like morphine, oxycodone, hydromorphone, or fentanyl. Regarding the use of the terms weak opioid and strong opioid, it's no longer applicable. However, it's understandable, especially we know that it's more useful to talk in terms of doses rather than weak or strong opioids. But this is what was introduced before in the 1986, and several recommendations are required for the update. Now let's move to the second part of the presentation, which is the role of pharmacists and how we can help our patients in improving pain management and their outcomes. Pharmacists actually, they are considered the most highly accessible healthcare providers. They can be the center of any health-related intervention or interaction with the patient. So yes, we can help our patients in order to improve their pain management, to improve their quality of life, especially with the application of the 4 A's: analgesia, activities of daily living, adverse events, and aberrant drug behaviors. So if we take care of having an appropriate indication and effectiveness of the medication, if it's improving the impact that it's having on the daily living of our patient, if we're monitoring for the adverse events, contraindications, and others, so by this we can help our patients to optimize their treatment plan. So for the role of pharmacists, actually the role of pharmacists can be established in 4 main areas. First, in self-care and encouraging self-care for the patients in pain management, so that they can self-manage their pain. In referral whenever required, and also optimizing the use of the prescription medication, and in collaboration with healthcare providers. So starting with their role in self-care, yes, pharmacists have a huge responsibility and role in advocating and in supporting self-care, encouraging patients towards self-care through communication with the patient, through provision of the quality of medication, through training, collaboration with the family caregivers and healthcare providers, and through promotion of health. So in pain management, we have many, in self-care, we have many OTC medications that can be used for the management of pain. So what we can do as community pharmacists is that we can help our patients to choose the best treatment possible for them based on their background, based on their history, and based on their concurrent medication comorbidities. So we can help them to choose an informed, or to make an informed choice where they are at the center of the decision-making process. Actually, a survey was done in UK in 2018, and it has showed that the community pharmacists, around 35%, they were discussing the pain with the adults for 2 to 5 times a day. So this means that, yes, we can have a huge influence on our patients' attitude toward the management of pain and the decision that they might choose for self-care and self-medication. How can we interact with our patients for pain management? We can adopt the pharmacist patient care process established by the Joint Commission of Pharmacy Practitioners. So initially, when we interact with our patients, it's very, very important to collect and gather appropriate subjective and objective data. Then we are going to assess this information in order to identify any drug-related problems in terms of indication, effectiveness, safety, or adherence to the pain relievers or analgesics. Then we're going to devise an appropriate pain management plan, including the setting established goals, then recommending appropriate pharmacological and non-pharmacological medication, and setting an educational plan. Then the implementation of this plan and educating and counseling the patient. Then following up, it's very important to follow up to make sure if the patient have established or have acquired the recommended goals, yes or not. The follow-up will be including the monitoring for effectiveness and toxicities, as well as evaluating the treatment plan, whether we have reached our goals or not. So while interacting with our patients and gathering information, it's very important to adopt the motivational interviewing way. Sorry, why the motivational interviewing? Because it means placing or putting our patient in the decision-making process, so they will be in control of their own treatment. This will help to get better adherence to the medication and better outcomes, because they will be discussing the goals of therapy, the concerns they might have about the side effects, about the cost, about their expectations. So this can help to improve the outcomes. So in summary, what we can say about the community pharmacist role in self-care for pain management is, first, to help the patients establish goals for pain management, to select an appropriate, to go for an appropriate assessment, to select an appropriate analgesic, and then in education and expectations. Starting with the goals, we have to help our patients to understand that the main goal of pain management should be to improve the quality of life, to decrease the pain rating, and to improve overall functioning. For sure, this goal, the percentage of achieving this goal is depending on different factors, including the patient condition, the type of pain, and the presentation, the other concurrent medications being taken at the background of the patient. The second important point for the role of pharmacist is gathering appropriate information so that we can have an appropriate assessment. So to assess pain well, we have to gather required information through the interviewing and the interaction or communication with the patient, so we can get more information about the location, the duration, the onset, description of the pain, its impact, and how it's affecting our daily functioning, and the history of the previous medications or analgesics used for the management of pain. So if we are having any successful or failure with the treatments, this can help to optimize the treatment plan for later. For the selection of an appropriate analgesic, as we've already told, this should be a shared decision with the patient. So we should cooperate with our patients in order to choose an appropriate analgesic, keeping in mind that this should be based on the patient's concurrent medications, comorbidities, medical, social, and family history. The last point in self-care, how can we help our patients in self-managing pain? Through educating our patients and counseling them. We have to counsel them about the expectations in terms of recovery and the effect or impact of the treatment, in addition to counseling regarding non-pharmacological and pharmacological methods in terms of benefits, risks, alternatives, and if the medication being recommended will suit their lifestyle or not. The second role that community pharmacists can help in improving pain management and patient outcomes is through the referral. So whenever we have exclusions of self-treatment, we have as community pharmacists to counsel our patients to consult their primary care physician or to seek medical attention immediately, depending on the condition. So usually if a patient in severe unremitting pain, or a patient having difficulty breathing, or head trauma, or impaired consciousness, or total loss of physical functioning, or in case of children less than 2 years, pregnant women, pain lasting for 2 weeks, or pain that is not resolving with OTC medications, in case of seizure. So we have a huge list of self-exclusions that we have always to keep in mind. Whenever a patient approaches with a self-exclusion of self-treatment, we have to tell them that they are not eligible for self-care and they have to consult their medical doctor or to go to the ER immediately. The third role that we might have in optimizing patient outcomes is through the optimization of the prescription treatments. This is the same process that we might use with the self-care, following the pharmacist patient care process and collecting, assessing, planning, implementing, and following up with the patient. With the exception here is that we are not choosing or selecting a medication because it's already prescribed by the physician. This is especially important for patients with chronic pain, because here we have several comorbidities like depression, anxiety, or sleep disorders. So we have polypharmacy, we have many medications that are dispensed together. We have high risk of drug interactions and side effects. And here came our important role in medication review in order to avoid any drug-related problems and in managing and preventing them. So what role can we help, or can we assist our patients with? We can optimize the prescription treatment through the appropriate assessment of pain, through also monitoring of medications, interactions and side effects, making sure that the dose is correct, switching or tapering medications whenever appropriate, individualizing the treatment plan and expectations, providing counseling regarding the benefits, the risk, the toxicity, signs and symptoms of overdose, and how to store these medications, and also to discuss the related risks of substance use disorder, and this is especially important with the opioids use. The last point that community pharmacists can help the patients with is through collaboration with healthcare providers. Community pharmacists can collaborate with the physicians, nurses, physician assistants, or nurse practitioners in order to help our patients to achieve the quadruple aim of therapy through ensuring that the patients are going to be satisfied with the treatment. We will have a provider satisfaction as well, reduction in the medical costs, and also at the end of the day, we will have improvement in the patient health outcomes in relation to appropriate pain management. How can we ensure this appropriate collaboration? Through informing the providers about any drug interaction or side effect or toxicity or possible problem with the prescription that should be discussed with them, answering any drug-related questions that they may ask for us, and also to ensure a better reception of the recommendations. So we have a few studies that were done to document the role of community pharmacists in managing the patient's pain and improving the outcomes. Actually, a meta-analysis was done, and it has shown that pharmacists led medication review was very helpful. It had reduced the chronic pain intensity. It improved the patient's physical functioning, quality of life, and the patient's satisfaction. Another study have also found that pharmacists led risk assessment of opioids. So the risk assessment of opioid was associated with better adherence to guidelines for the pain management and better opioid prescribing practices. So in summary, we can tell that pain management is complex, however, involving pharmacists, especially community pharmacists in the therapeutic decisions. This can help to save lives and money and improve the patient's quality of life, especially for minor ailments, disorders. Thank you so much.
Thank you very much, Iqbal, for that very rich presentation, very informative. And I'd love to invite all our panelists on camera. We have lots of questions coming in, and I can see that a lot of them are clinically focused. So we'll see how we can divide those up. But I just wanted to say that we started this today's event with Muriel, who really set the scene from a global point of view on the importance of self-care and the role of health literacy in enabling self-care. We're really pleased to see how the Global Federation supports the role of pharmacists and investing in elevating the role of pharmacists. And I have a couple of questions for you, Muriel, so I'll come to you. But then we went to Jonathan, who took us down to the pain and link to pharmacy, presenting Australia's examples and the impact of pain and quality of life. And a really, really good example, a small example maybe in health literacy using labels. And I know Muriel touched on e-labeling. So I'd love to have a mini discussion on that very quickly before we let you all go. And then Iqbal, bringing it all together to the level of community pharmacy. I know, Iqbal, you'll have to answer a lot of the questions here coming in from the audience, but that was really helpful in summarizing also some enablers for pharmacy. So thank you all for a very comprehensive and then ended up being very complementary set of presentations. So thank you so much. Muriel, I wanted to quickly ask you about, you touched on an important topic of digital health digital health literacy. And I wanted your views on where does the Federation and where do you see the role of pharmacy in using that as an enabler?
Great question, Lina. Thank you so much. I think speaking on behalf of GSCF, this is for us, we only started last year to actually deep dive on the health literacy, seeing all the reports that were highlighting how important it is for us to enable self-care. So digital literacy, we can't deny it. We can't just, ignore it with nowadays all the tools being developed. And looking as well at what happens during the pandemic when you have so much information online. How do you assess what is misinformation? What is the real information? How do you trust the right information? So right now we don't have specific project. I think we are trying to gather the right stakeholders to understand where we should be providing guidance, or at least like a statement at a global level. We've been talking to the WHO, who has been working quite a lot as well on the digital literacy, trying to see how you can develop guidelines on how to define what is a good digital tools versus a non-reliable one. Because a lot of, what type of data, how we have been as well discussing on health data. How do you ensure that the individuals, when they share the health data, how is it private? How can we ensure that this is going to be used appropriately and safely without any marketing things behind? So this is one work that we have done 2 years ago. We developed some guidelines for members to show that they commit for a safe and appropriate use of health data, showing them that whenever they develop a digital tool for the consumers, it's really not to use the data behind, but to build the best appropriate tool. So for the pharmacy, and coming back to your question, I think that for us, when we build that project, which still is yet to be discussed, we need to ensure that healthcare professionals such as pharmacists have the say and build that together with us. Like, how do you promote, how can you educate and empower patients as the first step when they buy a product and they need to have an app next to it, and help them like becoming more health literate? I hope this answered the question.
It does. Thank you, Muriel. And I'm sure when the time comes, FIP will be more than willing to contribute to your project and support that. But thank you so much. I'll come back to you with another question, but it will be towards the end. Jonathan, thank you for your presentation. Every minor ailment or condition comes with its own health literacy considerations, and you touched on a very important additional layer when it comes to pain, which is gender bias. And this is a really important issue, and thank you for presenting a summary of the roundtable we had in Civil. That was really helpful. But when it comes to how do we integrate eliminating gender bias into improving health literacy, it feels like a very real problem. But how do we try and address it through developing or equipping pharmacists with improving health literacy in pain?
Yeah, thanks, Lina. It's a good question, and there's two elements of improvement. One is the advice that we give, but also it's the literacy and empowerment that we give to our patients. So from our side, from a pharmacist side, number one, we should be reflective practitioners. We should be thinking about the types of patients we see, and we should be trying to improve our own practices. And one thing I would ask the audience is, if someone comes to you with pain, do you have an objective assessment for their pain? Or do you just say, what do you want? Like, how are you assessing pain? I suspect a lot of people aren't assessing it objectively in a consistent manner with each patient. This is just a comment of things I've seen myself in pharmacies that I've gone to and in my own practice, is that assessing pain is quite difficult to do in a community setting where it's not private for some people, and it's just, it may not be done in an objective manner, which leads to these variations in recommendations, variations to what we give our male patients compared to our female patients. So we want to just minimize that variation. The second point is around how can we help empower our patients? How can we help them be more engaged, to take control of their pain? And I think a lot of it comes down to expectations, and I think our language. So I agree with the other speakers, having digital labels, having digital information, having things written down are very important, but I'll keep pushing that the words we use are also very important. So one thing that's happened a lot in pharmacy is we often refer to analgesics as painkillers, and all of our patients then assume, I take this medicine, I shouldn't feel pain. But that's not the truth, right? You take your pain analgesics, you're not going to get rid of the pain, but we might relieve it a little bit. So that term painkillers, I try to avoid altogether. I say this medicine will help relieve your pain, but it's not going to get rid of it completely. And for some people, that's okay. What they really want is just to be able to do their morning walk, just to be able to do their gardening. It's not actually about the pain, it's about their quality of life. And so I think that means that when you talk to patients, make sure you're using language that doesn't over-exaggerate the medicine's capabilities, but also try to understand, what does the patient actually want? Is it pain relief, or is it just to be able to help around, help again at work, help in the house? And I think we make those assumptions of why they want the pain relief without asking them.
Thank you, Jonathan. And that's a really good point about using terms we use so frequently carefully, a little bit more carefully. Thank you, Jonathan. Iqbal, maybe I'll address a couple of the questions we're having from the audience to you very quickly. I have one from you, Yusufa. I don't know if you're able to answer this. It's about the pain management of sickle cell patients for non-opioid drugs and medications. So she sent in a couple of questions, especially in children. When it comes to body pain management, how do we deal with pain in sickle cell patients?
Yes, actually for sickle cell disease patients, especially for children, I saw in one of the questions concentrating on children. The pain management is very important because this is part of the disease. We try to go for prophylaxis in addition to the treatment. But the point here, the approach that we have as community pharmacists will be the same. It can be applied to all disease states. It's very important to be there for the patient, to optimize the treatment plan, and to gather the appropriate information, what type of pain they are having, are they going to be relieved with the treatment, or are they relieved with the treatment plan available now? If not, what can be done? Are there any drug-related problems that we might identify and to address in terms of indication, effectiveness, safety, or adherence to the medication? If there is any, then we can try to tackle these issues. If not, then we have tried to address an escalation in the treatment plan. We can go for combination of non-opioid treatment along with adjuvant therapy, reserving the opioids till the end. But in some cases, in severe cases where the pain is very severe, we have to reserve for the opioid treatment. But in general, our role will be the same in terms of collaborating with the healthcare providers in terms of good assessment of the pain, in terms of establishing goals for the treatment plan, recommending certain treatment in case if it's an OTC medication, if it's a prescription medication, to optimize this plan in terms of monitoring, in terms of counseling and educating our patients, so improving their health literacy, and consequently, this is going to improve their the outcomes of our patients.
Thank you, Iqbal. Another question that could be you and Jonathan or any of you is an attendee is asking about the role of CBD oil in the treatment of pain. And we know that cannabinoids are becoming more and more mainstream. Of course, this differs in different countries. But do you have any comments on that, Iqbal and Jonathan?
On the use of cannabinol oil?
Yes.
For the management? Actually, it depends on the setting. Not all countries approve its use, so it could be an option for later in the future, especially for cancer patients. So this is a good option. It was studied. It had shown effectiveness in the treatment, but still, it depends on the legislation, the rules of the countries being there.
Great. Anything you'd like to add?
Look, I agree. It depends on the regulations. At the moment, look, it's not first line anywhere. It's probably not even second line. It might become third line at some. So it is an option, but it's not something that you should be seeing commonly. It's something that you really got to try out your other options. And only if you have no other options do we start to use it. The evidence is weak. A lot of low quality studies, some high quality, but conflicting evidence. And like all medicines, they're not without side effects. So I know their recreational use has made them people quite open to them and to see that they're quite safe. But when you're using it medicinal quantities, the sedation can actually be quite significant. So I'm not going to say you can't use it, but you got to really consider your other options before you get down that pathway.
Thank you, Jonathan. Before I move on to a second round of questions, Iqbal, I'm wondering, while we have you, if you could type some answers to Professor Ganan Chandran. He's asking a couple of quick questions. That would be really helpful. Thank you in advance. And while, thank you. And Jonathan, back to you. There's a question to you, and it actually links to my second question that was going to be to you. You said you check the intensity of pain and then give the medications accordingly. So please give us some tips for better pain evaluation. And I was just going to ask you to tell us more about the essential pain management program you touched on in your presentation. I don't know if these two are linked, but what would you like to tell us about this, Jonathan?
No, you're right. They are very much linked. And so, we can't cover everything today, but go to the Essential Pain Management course. They have a good acronym called RAT, where how it helps you to assess and manage pain. The main theory behind that course was, in the acute care setting, with first aid, everyone knows, do your ABCs, right? Airway, breathing, cardiovascular system. Everyone knows that. But with pain, what's the acronym you go to? Is it just good luck? And so the one that they prefer is RATS there, where we're assessing and giving treatment accordingly. Now, when I say to assess it, what ways can we do that? I think we have to be very clear whether this is acute pain or whether it's chronic pain. And I'm going to be very clear about that from the very beginning. And if it is acute pain, then it's something that's going to be very short term. And then generally, you'll probably just be prescribing the same medicines in a community pharmacy for something short term, just depending on their other comorbidities, like cardiovascular diseases. You might want to avoid using the NSAIDs. But you can see how gender isn't really one of those things you consider. Yet again and again, we just see gender impacting people's decisions. So I just really want to push that we need to find those objective ways. I suspect gender becomes much more important in the chronic pain space. And I think what is important to know with chronic pain is that the goal of chronic pain is not about relieving pain. It's about having a quality of life. So your measures for chronic pain should be about what are your goals? And what functional outcomes do you want here? Is it that we want to be taking our walks in the morning? Is it that we want to be getting out to be able to have our brunches with our friends? That we need to move away from pain scores when it comes to chronic pain. We need to think about how can we help you do your day-to-day life. And I think that will help us be a bit more, to allow the patient to become part of that decision-making process more.
Thank you, Jonathan. There is so much emphasis when it comes to pain on a very tailored approach, depending on the patient's condition, but what their expectations are or where they want to be. So thank you for emphasizing that. I want to go back to Muriel, maybe taking us back up to the bigger umbrella, but from an education and training point of view, and I know the Federation works with many healthcare professionals, but what is the view on improving health literacy and enabling self-care through healthcare professionals? How can we improve the education and training of healthcare professionals to this end?
Thanks, Lina, for the question. I think it's part of the roundtable that we had 2 weeks ago with all the different stakeholders. So if I may recall the white paper that we recently published, we had a set of recommendations there that not only GSF can act on. I think it's like you said, it's an umbrella. So it's everyone has to take a part of it and play a role. And for education, for example, we identify that sometimes we need to educate healthcare professionals as well on self-care practices. You can't just assume that they will do that at an individual level. So for us, we would like to initiate discussion with pharmacists, understanding how you can include that into the curricula of these professionals to better give them the tools and the knowledge to then empower the patients. Because you can't just target the patients and assume that all the healthcare professionals can do the job. So I think there's different levels and different recommendations from a policymaker level to the healthcare professional to the NGOs, where there are several actions. And talking about including that into the curricula is one of the targets that we identified as helping putting the health literacy for self-care a priority.
Thank you so much, Muriel. Really helpful. Jonathan, we have another comment from Ilan. Many community pharmacists face comments like, "This is what my doctor told me to do," which is fine until we see that things can be managed better. How do you suggest that we address the hesitancy of patients to be open to other options, especially those coming from pharmacists?
Yeah, I wish there was one simple solution, a silver bullet that every single case, you just say this and they magically listen to you. But I think we just got to remember that people make decisions for a variety of reasons. And the more we know our patients, the better we know them, the better we can help them overcome those issues. So is it the fact that they've tried other things in the past and now they don't want anyone touching it but their doctor? Right? They've had so many negative experiences that no matter what someone says, I just trust my doctor, I'm going to do that. Or is it just because of the hierarchy? Is it because of, is it because they have fear that if they don't take this, it's going to get worse? So I don't think there's one, and I also don't think you can convince everyone. I think some people are open to it. And again, this is getting to know them better. But I think it just comes down to asking them, okay, look, I've got this new medicine. What's our goal with this? Like, what are we expecting? How are we going to monitor that it's working or not? And then as that comes out, you can also be like, oh, okay, well, it sounds like you want to do this. Have you tried other things as well? Are you taking your acetaminophen with this as well? Are you taking other things? What is your morning routine? I think asking those other questions, it naturally enters in, and then they go, oh, actually, I haven't thought about that. And I think you just have to come at it from a point of just wanting to understand them better and their goals better, and adding your little 2 cents along the way, more so than, oh, don't listen to your doctor, this is a lot better. Try not to be as adversarial. At the end of the day, we are a healthcare team. We are on the same page, but we have sometimes different priorities and different perspectives. And it's helpful that we understand others before we enforce our own.
Thank you so much, Jonathan. I'll go to Iqbal for one or two small questions, and then a final round to everyone. Same question to all on access to patient information. So Iqbal, thank you so much. I know you've been busy typing. There's a lot of questions coming in for you. So maybe I'll use this time to address a couple of them live.
Yes.
I know we may not be able to finish all questions from the audience, and we'll do our best to get back to them after the event. But one question coming in, the management of excruciating pain, I'm assuming, for cancer patients. Very quick couple of thoughts from you.
Yes.
I know it's a big topic. We can't cover this. This is a
Sure.
whole event. Yeah.
Yes, but the main, first of all, for cancer patients, it depends. Not all cancer patients are going to suffer from severe pain. So we are going to adopt the WHO ladder for the management, but it can be individualized depending on the patient case. So initially, we start with the non-opioid analgesics, which could be acetaminophen or NSAIDs. Some other adjuvants can be added, like TCAs, antidepressants, anticonvulsants, some neuroleptics, corticosteroids, bisphosphonates, if we have bone pain associated with the cancer. So different adjuvants can be added, individualized according to the patient's pain. Then we can move up into the ladder to add opioids. If the pain assessment increase and the rating of the pain is more than 5, then we have to add opioids. Depending on the dosing, we can go for small doses. Then we can add up till we have a good management of the patient's pain. That's the approach in general.
And I suppose the approach of assessing pain before tailoring an approach to it would apply to the other questions on back pain management after cesarean delivery, or a person who's just 88 years old, not suffering from any chronic diseases, but feels pain all over the body. So we have different pain is a huge spectrum. So how do we manage these cases when they come into the pharmacy?
Yes, actually, for an elderly patient suffering from a severe pain, what we can tell is that there could be any problem suffering that the patient is suffering from. It could be not pain. It could be we have to assess the patient's mental health, the patient's other physical conditions. It could be anemia that the patient is suffering from. It could be other physical condition. So a thorough assessment should be done in order to establish what the patient is suffering from, if it's real physical pain or other problem. And based on that, we can go for the same approach, whether the patient is eligible for self-treatment or not. If eligible, we can try to help with OTC medications. If not, we have to refer. Here we have also to emphasize on the role of non-pharmacological treatments. We have to emphasize on the exercising, meditation, on the acupuncture, acupressure. All of these procedures have shown some effectiveness, and they can be helpful in some cases for our patients, especially, for example, for the C-section patients. On the long term, they can make use of the non-pharmacological methods.
Thank you, Iqbal. And a final round of questions to everyone before we close. One of the enablers for health literacy and self-care we've pre-identified, and we're trying to delve into the program through the series, is access to patient information. And maybe starting with you, Muriel, obviously this will be a general question, not just to pain management, but has the Federation looked into this, or has this come up as one of the enablers for self-care and health literacy? Where does access to patient information fit in all of this?
Sorry, Lina, I just missed the access what?
To patient information or records.
It's a great question as well, because like Jonathan said, there's not like an easy fix to that. But if we look at when we developed this self-care readiness index, which looked at 20 countries and their readiness in terms of self-care, we looked at different enablers, from the regulatory environment to the health policy environment to the patient empowerment. And the health records, the EHR records, were not available everywhere. Actually, only a few countries had this EHR available. So this is something that we would like to promote, to facilitate the communication between a physician, a pharmacist, and the patient, to make sure that they have safe data use, but as well that there's a continuity, because in terms of self-care, we don't have any records. right now it's only medical records on prescription medicine. So we don't have the visibility of the entire environment of the patient and the individual. We don't know, we don't have the full picture, and that makes it very difficult for pharmacists, for example, to have the entire history of the patient. So like Jonathan said, you need to ask questions, you need to get to know better your patient to advise them better. But at the same time, having an electronic record would definitely help them guide even better the patients. So that's another area where, you know, at the policy level, or bringing together regulators, policymakers on the same table to trigger discussion and see and show the value of establishing such a national tools is essential, and that's where GSCF can play a role.
Thank you very much, Muriel. So I'll take that question to Iqbal. Again, Iqbal, in practice, how impactful is having access to patient records? We know, of course, it's helpful, but what does this look like in reality?
In reality, regarding, sorry, but
having access to patient records, how does that support in the management of body pain?
One of the most important points, and it's very helpful because patients might not come to the same pharmacy, to the same physician. So having access to these records will help us to get the necessary information regarding the patient's history. They might miss something while we are interviewing them and discussing their cases. So having these records is very important. Actually, we're suffering from this in our country. We don't have this access to medical records. We don't have a server that combines all community pharmacies or the hospitals or physicians' offices. So we're having a huge problem with that, and we're seeing the impact of the absence of such access direct in our practice. We're having higher number of drug-related problems that we identify and can be managed or prevented with having a better access to the patient's files. So yes, this can be very helpful, especially in pain management.
Thank you very much, Iqbal. And finally, Jonathan, what are your thoughts on the issue?
Yeah, there's two main health records I think are important in pain management that have been implemented around the world electronically. First is prescription drug monitoring programs. So in a lot of countries, all opioids, narcotics, benzos are recorded there so everyone can see them. And that's called prescription drug monitoring programs. It's mainly in the Western world that has them. But we've found that if you make them mandatory, it's much better than when they're voluntary. When clinicians opt into it, they often don't. But when it's mandatory, we finally actually see what the patient's on. And the benefits there is we reduce the amount of opioids, reduce the doses of opioids, and we definitely reduce a lot of doctor shopping. A lot of people get picked up going to lots of different pharmacies because you can see it now in the prescription drug monitoring program. I've seen you just went to another pharmacy 2 days ago. So those have been really beneficial. They have gone implemented around the world in different modes, but I would say mandatory is the best way, but often it has to start voluntary. Then you prove that no one's using it, then it becomes mandatory. That seems to be the general direction we go. There was some debate at one stage where in the US, they introduced it mandatory and it made people have higher rates of mental health crises. And the assumption there was because they were taking everyone's opioids away, they're all having mental health crises. But what we've seen from the US is that they were very, very severe in how they took opioids away, like people getting to withdraw from very high doses. And so we don't recommend you use these programs to stop and restrict access on people on high doses, but to help better manage their pain and to reduce it and taper it slowly. So don't just cut people off because the prescription drug monitoring program says they've had too much. So that's the first one. The second is actually like the whole patient record, right? So some countries have this, some don't. In Australia, it's called My Health Records. So we do have this now. We made it opt-in to start with, but it was voluntary and nobody used it. And so now it's opt-out. Everyone gets one unless you say otherwise. And we've done some research that's found like 90% of people have a record that you can review in a pharmacy. So it's definitely been very helpful from that perspective, that now we do have that background information. Things to note though is that community pharmacy time is tight. You don't have a lot of time to review these. And often the program, it sounds great to have all this information, but it's not organized in any logical way. There's just information everywhere. You can spend hours trolling through it. So just having it sometimes isn't enough. It needs to be usable and user-friendly, like from a clinical decision-making point of view. But some of the research we've done as well, looking at these electronic systems, it shows that like a lot of the policymakers, once they've paid for the product, they don't want to hear what's wrong with it, right? They go, we've paid for it because we think it works, right? If we didn't think it works, we wouldn't have paid for it. So why are you coming to us with all these things to change? Like it already works, just leave it alone. And so I'll just say that at the start, when it gets implemented, get as much help as you can to optimize it. Make sure it's designed for clinicians in mind, because once it's in place, if those things aren't in place, it's very, very hard to get those things later.
Really sobering point, I think, Jonathan, because we always overestimate the value of having access to patient records, problem solved, but you've highlighted an important point that often it's harder to manage all that information, and it has to be designed in a usable way, otherwise it's of no use. It's a really, really good point, Jonathan, thank you. We have more questions from the audience, but we're going to have to close. I know a couple of them are asking about the non-medical interventions to pain management, and I'll ask them to go back to Iqbal's presentation earlier in the recording. She has summarized some of these approaches, and I know one of the questions here addresses meditation as well. So I know that there's a lot of interventions, and maybe this is a topic for another event. It seems that there's a lot of interest in the clinical guidelines to pain management. And I don't know, Iqbal, if you have any time to answer Ramdini's question in typing, that would be fantastic before we close. Yes. And before we close and just tell you about our next event, I'd really like to thank our panelists, Muriel, Jonathan, Iqbal. You've been fantastic and superstars today, and really personally enjoyed moderating this event. Thank you so much, and we hope to see you with us in future events and roundtables and in the Congress, I hope. Thank you once again.
Thank you, thank you.
Thank you, Lina. Thank you.
Thank you so much.
Thank
you, Jonathan. It's been a pleasure. And before we close, I'd just like to remind everyone of the next event in this series, which will focus on children's fever management. It will take place on the 19th of April, same time as today. We will be announcing the list of speakers and experts who will be at that event very soon. So we hope you can visit events.fip.org and pre-register for this event. We hope to see you all there. And the next slide is a reminder to everyone, in case you're not aware, Jonathan, that's closer to you. Brisbane, our 81st FIP World Congress will be taking place in Australia this year between the 24th and 28th of September 2023. The theme of the Congress this year will focus on pharmacy, building a sustainable future for healthcare, and aligning our goals to the Global 2030 goals. These are some important dates. Of course, first, you can visit our website, brisbane2023.fip.org to register. But also, please consider submitting an abstract if you have any evidence or outcomes or initiatives you'd like to inform the global pharmacy world of. We hope to see you all at Brisbane this year. And last but not least, a simple reminder of the FIP Pharmacy Education Journal. We're using some of our events to promote the excellent work of this journal. The PEJ is a fully open access peer-reviewed journal that has been serving the domain of pharmacy education, workforce development, and associated fields for over 20 years, but also looking into practice as well. PEJ specifically supports and encourages early career academics, scientists, and practitioners to publish work with a no-cost route to dissemination, especially where scientific English is not a first language. So PEJ supports equitable access to research and science, and we want to encourage you to consider that platform for your next publication. And finally, check all of our future FIP digital events in the website. I've mentioned a couple of times events.fip.org, where this recording, the recording of this webinar will also be published on there. A final big thank you to everyone for attending, for listening, for staying with us till the end. We really appreciate that. and we hope to see you in future FIP events. Thank you, and thank you so much, Noor and Marianne in the background, for facilitating and coordinating this event. Thank you so much.
Thank you.
Thank you. Bye for now. Bye, everyone.
Bye-bye.